Thank you, Bala. So Purva has covered most of the topics, and I will be at a short notice of one day. I could gather two from my whatever stuff I have. Two cases where we have had something where we broke the catheter, the wires, and still managed to retrieve them. So let me just start. So the wire, when we say the wire, it may mean various things. There is a news portal by the same name, The Wire. There is, Adrian will tell me, there is some American drama serial going on by the name The Wire. So for us, wire is integral part of our interventional nephrology. We may say that we breathe the wire, we eat the wire, we live with it. And if you lose the wire, then obviously you are going to have a lot of problem while doing interventional procedure. So having said that, just
it's at the bottom, Hemant, of your screen.
yeah, but that's not getting out that other thing.
Then what you can do is just move that
just
sidebar.
1 minute. Let me try here from current slide. Yeah, there you are. Okay. So this is the first case where the elbow AV fistula angioplasty was being done and the wire broke, and how we retrieved it. So this is the, so now when we are dealing with a fistula, many a times it so happens that we have to first study the whole circuit. So at that point of, oh my, 1 minute. I don't know why this is not going. I'm sorry. The first slide, first video we missed. Anyway, so there was this distal perfusion chart, and right up to the palmar arch, as you see here, the circulation is intact. So there was this, now as you see, there is this anastomotic. So we had put a wire from the venous side, and we thought we'll be able to do it this way, but it didn't happen because it had a peak. And in the meantime, what happened was just one. Oh yeah, good. Now I can. Just okay. Now you see the wire which came from the vein, and we tried to put it into the artery, already had a kink over here. That was probably because of the angulation of the fistula, which was already existing. So we decided to leave that wire just not to lose excess, and put another wire all the way onto the vein, and decided to do plasty over there. Now see what happens is the balloon is inflated, and one of the assistant without, see, this is the action. He pulled back the balloon without deflating it. And the next thing we realized was, you see this?
Oh.
Wire is broken over here.
Right.
Yeah.
Wow.
So we said, let's finish it off. So we finished off the angioplasty, and so that was a tight one over there. We have got a good one over here. So this job is done, but with the broken wire lying there. So now how to retrieve that wire? The first thing we did was, okay, sorry, one more here.
So that wire is in a branch of the fistula, right?
No, it's in the artery. It's in the artery.
Oh, it's in the artery.
You'll see this. Okay. You'll see this. Hold on. Okay. So
right now I see it.
Now you see this artery, and I mean the wire all the way up there in the artery. So what we tried
Right.
was this. So many a times what we do in such a situation, 1 second. So this is your head under catheter. You just try to twist it 360 degree around the wire, and many a times it acts like a snare. The wire gets entangled, and then you can pull it out. But even that didn't work. So then what we did was this maneuver.
This catheter is coming from where? From the artery?
No, the broken piece is, so we had come from the vein across the body of the fistula and parked the wire into the artery.
But Hemant, where is the catheter coming from? Is it via the femoral route and through the subclavian?
No, the earlier study.
No, your current catheter, the H1 catheter which you put, where is it coming from?
Femoral artery.
That's what.
That's what we're asking.
Yeah. Okay. This is now from femoral artery, and so this has obviously not worked. So we took the same balloon and blocked this. Now, having blocked that, now we went to the proximal end. So this is where it is. We came from here, put this, grabbed it, and then the whole wire was out. Check the angio just to make sure that there is we have not caused any dissection of any of the arterial side, and the fistula was also fine.
So that was the snare, right? You to use the snare to grab
balloon.
No.
Balloon he has used.
No, we used the balloon. I'll show you.
He used a balloon to anchor it, but how did he grab the proximal end of the wire?
So we used the coronary wire.
I'll
show you 1 minute.
No, the one before this. One before this.
Yeah.
I think one before this as well.
No, couple of
one
them.
before this.
One before this.
This one. I think it's this one.
Yeah.
No,
one.
maybe. This one.
Yeah.
So let it be this way. So you see, this is the this is your catheter.
That's in the aorta. Hemant?
That's in the aorta, and this is the coronary wire 0.014.
Yeah.
Which we had angulated here. So with the balloon pushing the wire, broken wire, and this was looped here. And as we did that, you see slowly.
Got it. So you made a snare out of it.
Out of the wire. That's what I was going to ask too. Yeah.
So because we had pushed it, we had already created a loop here. Purposely, this loop was created.
Got it.
Yeah, and with this, now see how it is catching. Saw that?
Right.
Yeah.
So now, once we were in the wire, then we could just pull out everything. So see this.
Yeah.
This wire is coming. Now there you are. You can just pull out the catheter and
with the wire.
Well, the wire will come out. So
great, wonderful.
And,
Good, Valentine.
Yeah, Hemant, what is above your catheter? There is a device there. Is that coming here?
No.
In the subclavian? What is that?
So no. See, what had happened was because when we put the balloon, we had to put a wire. No? So
okay, that's the wire of the balloon. Okay.
Wire of the balloon was parked all the way there. We didn't want to lose anything now.
So you have parked that wire. You've come via the fistula vein across the anastomosis and up to the subclavian artery.
Subclavian artery. Yeah.
Right.
Somewhere here, we pushed so balloon would have blocked it. Otherwise, chance of this. When we try to manipulate something here, the wire may migrate backwards into the forearm or wherever. I don't know.
Yeah.
So the balloon was blocking it. So we knew that end is secured. So we can do some manipulation here and try to catch hold of it. Okay, so that was one. And then let me take you through this. So we always think that temporary non-cuff catheter stiff IJV is a cakewalk, but then you can be in trouble with that also. So this was a 56-year-old female, AKI, needed dialysis. So usual call from the ICU, you are just on your way to the hospital. You tell your resident, put the right IJV catheter. This was a lady with dengue fever, AKI, and he puts the catheter. Dialysis is started. I have not yet seen this X-ray, and then the call comes. There is no flow. So if you realize here, and I'll show you a close-up view here. See, the first thing you realize is that this is blunt here.
Yeah.
Second one you would have realized is it's quite high. Let me see
yeah,
see
it's
this,
just below the clavicle.
Yeah, the regular, even if you put a 13.5 centimeter, say Mahurkar WMN or Aero WMN catheter, it would at least be somewhere at the
yes.
SVC-RA junction. So cavoatrial junction. So this is way above that. It is blunt, and if you see carefully, something is jutting out here. Do you appreciate that?
Yeah.
J-tip
Yeah.
where my arrow is moving. There was this. I saw it immediately and realized what had happened. And one more thing you would realize is that, you know, this typical WMN catheters have the distal tip, which is radio opaque.
Yeah, it's blue on when you, the catheter is white and that tip is blue.
Tip is blue.
And that is radio opaque.
So now if you look at it carefully here, I mean, you would probably appreciate when I show you the next pictures. This is how the whole catheter has got, you know, doubled up.
Doubled up,
yeah, somewhere over there.
Because otherwise there should have been a tapering tip over there.
Exactly. And see, this part is more opaque compared to the remaining part of the catheter. And that's probably the distal tip of the WMN catheter.
Yeah.
So then luckily I could put it. So I realized it immediately what had happened. So I put a wire from here, and luckily it could come out from one of the side end, and we could remove this catheter. So when we removed this catheter, and you examine it carefully, something is just jutting out, and then a closer look at it, you see this winding, I mean, the serrations here, if you appreciate. So now I pull it out with a forceps, and this thing is coming out from here. So now you understand. So where it had broken here, the catheter had got like a kink, and then it got doubled up on its own body proximally. That's why we are seeing the blunt tip. So then more pull out, and then this is how it was. This part was broken. Now, when this happened, luckily the dustbin had not been cleared. So we went into the dustbin, pulled out this wire, which was lying in the dustbin. So luckily for us, so we could actually do the postmortem as to what has happened. So we found this wire over there, and then luckily looking at it, we could. So if you realize, this was the wire, and exactly this part had got, macerated. Part of it came, got retained and
sheared off from the rest.
Yeah. I'll show you the broken tip. And you see, this was the tip where it broke.
Right.
Yeah. So now you appreciate what had happened exactly. The point of break and the part of the wire got retained. So I was just trying to figure out how this could have happened. So the learning point here is that from that, I made it a point for the resident to document it in writing after every procedure. The Guidewire which went in should have come out in the same shape, no kink at all.
Right.
If there is any 0.1% resistance while pushing the wire in, you are going in, something is wrong. And what Purva was saying, that Guidewire going from right IJV to left subclavian, or right IJV from left IJV, whatever. Understand one thing, the Guidewire tends to take the path of least resistance. So if the Guidewire is getting deflected, there is very likely chance that there is something wrong inside the vein itself. So I don't allow anybody to apply even a centimeter or 0.1 centimeter of the force while guide wire is being handled. And then these are the two things which I picked up from, I don't know which hospital's website this was there. This is not mine. So either because of shearing or kinking, as it has been shown here, if this happens, then it's very high chance that your guide wires will break. So I'll end here and then I will the discussion.
I thought it was beautiful what you just showed, and especially what Purva showed. You know, we take the guide wire for granted, but a fantastic presentation by the both of you. Wow, that opened my eyes. If I can add a couple of things. The first thing is, you know, as you all well know, never manipulate a glide wire with the needle in place. We've had many cases where the coating of the wire, and this is called as polymer embolization, and we've written case reports on it. It can mobilize to the heart, and it can look like an MI. It can go to your feet. It can go to the kidney. We've had one where we did it in a clotted access, and when we took out the access, you could see the polymer inside the access, and it shows up as a blue material. It can go to the brain, cause abscesses, and you can even have a stroke. So that's the first thing. The second thing was, you know, Purva showed that repeated use of the glide wire. So when you're using the sharp needle, yeah, you can break the guide wire and you don't even realize it, and you're reusing it again and again and again. And that's where the danger happens. The third thing I always like to do is whenever I insert, and like you all correctly said, it should be smooth and it should go flawlessly. But it is always good to do it under fluoro and look and see where the wire is going. You never know, because that wire can perforate a vein which is so thin. And we've seen it. It happened to me. Thank God it doesn't bleed. Thank God. The other thing that I wanted to say was, you know, quite a few times, like Purva said, you're passing the wire and it's going from one end to the other end. In such a case, I would suggest, instead of pulling out the glide wire, if you have a sheet, take out that needle. If you have a micropuncture sheet, put the sheet over it and now manipulate the wire. Because once the wire comes out, you're struggling back and forth. But I've used it many times where, you know, my wire will go up in the neck and the first thing the patient will tell me, my ear is hurting. And so I know immediately I've gone up in the ear. So I pass a micropuncture sheet over it and just pull the wire back and then just guide it down into the heart. But, you know, conditions like this, like you've shown, you have to think outside the box. And, you know, I congratulate him. And that's a great technique that he has shown. You know, you have to just, I don't know, you have to just be, you have to think outside the box and come up with some novel techniques of figuring this out. The last thing was Purva showed the case report of guide wire in the femoral vein. We had one like that, and I was all set to put a snare. And all we did was we pulled that aldol or the temporary catheter back, and the wire was just sitting right there, and we could just grasp it and pull it up. And so we were fortuitous that nothing bad happened. That's all. I think that's all I wanted to add.
Yeah, I think thank you, the two presenters. I think for the beginners, this is not to scare anybody, but to warn you that there can be problems even with innocuous temporary catheter insertion if you don't take care of the points mentioned just now. And also to give you the positive thing that there are methods to, you know, come away from the problem also, like how they did all those manipulations.
Dr. Bala, can I add one more point?
Yes, Lobo.
Yeah, Purva mentioned something about catheters getting misplaced, and there's been a discussion on the forum as well about somebody shown the catheter which has drilled through the right atrium and gone into the pericardium. Now, that's actually a very rare case where that catheter was being used. It was clearly in the right atrium and it has subsequently perforated. But what's not uncommon is at the time of insertion of temp cats, most often, that the wire seems to have gone smoothly, the catheter has gone smoothly, and then when you try to aspirate, there's no backflow of blood. And that catheter has either gone into the peritoneum or into the pericardium or into the pleura. And the first panic reaction sometimes is pull the catheter out. The catheter should never ever be pulled out blindly at the bedside. The catheter position should be determined. I've seen 2 deaths of where the catheter has penetrated through the vein, mostly the SVC, and gone into the pleura, and it's plugging the hole over there. Now, the pleura is a big potential space. You take out the catheter and that vein just bleeds into the pleura and the patient exsanguinates within minutes. So the catheter should always, if it has to be removed, if a catheter looks to be in a wrong position or there's no aspiration of blood, it should be removed in the operation theater. The CVTS and other surgeons have got lots of techniques. One of our surgeons puts in a thoracoscope, and he takes through the thoracoscope. When you see the catheter coming out of the vein, he takes a purse string suture around the catheter, and then you can pull the catheter back into the vein and he just tightens the suture. So no major thoracotomy either, but it saves the patient's life. And once your catheter is back in the vein, you can either pull it out completely or you pass a guide wire and reposition it under vision. So that was the one thing, because the first panic otherwise is take out the catheter. And I've seen 2 deaths with catheters, including one was just a simple central line put in the ICU. No flow, it was pulled out and the patient died within 20 minutes. So that was the only additional point I wanted to add. And the other thing, as Adrian said, I also always use a sheath to reposition. It offers me one more thing. I can push in some contrast and see why exactly my wire is not going. So is it just a kink? Is it just a position? Or the vein is just completely occluded and there's no point in trying to push a stiff wire through?
Right. Good point, Valentine.
But the case discussed in the WhatsApp group, it was 9 months after the incident.
So that is a rare, that's a real rarity.
So Bala, it's possible that the catheter in that particular case was abatic against the wall of the right atrium all the time. With sheer force, it must have drilled a hole over a period. That's why it happened after 9 months.
Hemant, there is another case. I think it's from Mumbai. I can't remember. Maybe Nair Hospital, where there was a case of a guide wire which had gone and come up into one of the cerebral venous sinus thrombosis. It was published in IJN a few years ago. I think 2 or 3 years ago.
Karthik, you can unmute everybody so anybody can.
And
see, that case has again brought in the controversy, which is the ideal position to leave the tip, whether inside the atrium or in the junction.
It has to be in the atrium, but not abutting the wall. In the SVC, when the patient raises his hands, the catheter will frequently come higher up and you don't get a flow. So most of the tunnel cuff catheters, even the guidelines say, should lie in the mid-right atrium.
Right.
I don't know what others would say.
I mean, in couple of cases, Valentine, I have deliberately, I distinctly remember 2 cases where there was a big crack in the right atrium. And we just couldn't do anything. It was chronic and it was like a hard mass sitting there. So there we could luckily put our catheter over a wire across the clot, deep into the right atrium, and then left it there. So
that can be done. But Hemant, you wouldn't always do that under vision, na?
Under vision in the cath lab.
In the cath lab, that's what I mean.
And couple of times we have even even bolder and pushed it all the way into the upper part of the IVC, and it works well.
I think the other thing which came out in was in Purva said about forcing dilators. So dilators should never be forced, and it's not really necessary. When we are putting a tunnel cuff, we can see where the dilator is going because we have vision. But otherwise also, you only need to dilate from the skin to the vein. There's no need to push the dilator its entire length in. And that's often where dilators perforate something. So I think the dilator just needs to go maybe a couple of centimeters to reach the vein.
And that is at the same time, make sure that you have decent length of guide wire getting out of the dilator all the time. I mean, so to say, somebody is just holding the tip of that proximal tip, straight tip of the wire. So there's no way you can lose it inside the vein.
Bala, this is latex.
Yes.
Hey,
Lal.
excellent presentation, Hemant. Really
Thanks.
nice. I really loved your coronary wire technique.
Yeah.
It makes it's very interesting. It's really good. One quick thing, I know it's already hour and a half into 2 hours close to, is what we did was we instituted a central line insertion checklist, which is going to be done with the nurse at the bedside while any bedside catheters are put in, whether it is central vein or dialysis, acute dialysis catheters. As part of that, we have a series of safety steps, including one in which the guide wire has to be taken out. The proceduralist have to say the guide wire is out and intact, and that intact tip should be visualized by the nurse who is actually doing the checklist. Because what happens is even today, we get these lost wires, leftover wires, and you ask the residents, they will say, oh yeah, I removed it, you know. So as a safety net, we have made this as a point that even the tip of the guide wire should be visualized by another person other than the proceduralist. That's basically helps, and especially when we are not physically present, and definitely when we are not in the cath lab and its procedures are being done at the bedside, this kind of a checklist will really help to prevent these issues. But other than that, I think you guys spoke pretty much everything about all possible scenarios and how to handle this. Excellent presentation. Thanks, Bala.
Thank you. Dr. Sai Sundar, you have anything to add? Karthik, you can unmute everybody. So any quick comments or anything to add?
Sir, one question to Dr. Hemant, sir.
Hey, Dr. Bala, this is Sai.
Yes.
So the only thing I would like to add is if you are snaring a guide wire out, just remember that the guide wires tend to behave the same thing. You can shear more easily when you're trying to snare it out. So when you're landing the snare, make sure you take the snare all the way to the core of the wire, so you don't like ribbon it out inside the body. So that I've had ones that happened to me. So just because depending on where you land the snare to pull the wire, it'll just open up the ribbon without holding the core. So you might need a second snare to go to the core and then pull the whole thing out.
I mean, you'll have to go beyond and, catch the problem. Yeah.
Yeah, I mean, what he's saying is that hold the body of the catheter and not just the floppy tip.
Right.
That's what you say, right?
Right.
No, you can unravel the whole ribbon core of the J wire. Like how it unravels for you inside the catheter, it can happen for the snare too, much more easily, because the snare is another wire, so it can just hold it and pull it off the core. So just go to the core. So just go to the, like when you don't snare the very tip of the J wire, just take your snare into the wire approximately, I think 5 centimeters. Most wires have the core, so I think at about 5 centimeters is where the core ends. So take your snare all the way into the wire and then snare it right there and then pull into the sheath.
Yeah, it was a good point. Yeah. But maybe most of the nephrologists may not get to, take up the rescue procedures. But anyway, nice to know and learn all these things. Okay.
Hello.
Yes.
Madraki from one small question, like you were telling, the permacath, like TCC abutting the right atrium, how will make out other than free flow, like in the two-dimensional view in the cath lab? Like, is the catheter free or it is abutting the wall when we are completing the procedure of catheter insertion?
Maybe
if it is along the right heart border, then it may be likely to be abutting. If otherwise, you would see it lying freely in the center of the right atrium.
Hanging, yeah.
The simple thing is do a check angio through one of the lumens of the
catheter. That also.
So if you see it lying freely right into the middle of the right atrium, then it's not abutting anything. If there is a dye all around equally. It's like a routine. If you are doing the procedure in the cath lab, a check shoot is always taken, irrespective of whether you feel it's correct or not.
Okay.
the tip
Right.
position. Yeah, it's like
And
a
that-
protocol. It takes hardly 2-3 cc of dye.
Okay.
And it
Per-
will also tell you, I think Hemant is a good point. If you shoot, then after that, it will also tell you about the anatomy of the right atrium.
Right
You know, there's
atrium,
different
exactly.
anatomies of the atrium.
Mm,
And so you might have to change that whole catheter and put another different catheter because the right atrium is actually lower down
mm.
than what you thought it is.
Okay. Yeah. Yeah. Good point.
So for next time when the catheter malfunctions, you know which catheter to choose,
Yes.
which tip to choose.
a great point. Thank you.
Right.
We should get more ladies on this as chairs, Bala, because
Yeah.
I'm all for win. I'm all for it. ACP is very much on this, you know, women, minorities, they always want that in all their presentations. I was one of the chairs for the not the chair, on the scientific meeting committee for ACP this year. And they told me they want equality, more women, more minorities. And we need to push more women up here. I really think you need to do it. And you're doing a good job. Just get it.
I
Yeah,
agree, and they have told me the same thing. You know, this time for the ASM week, Bala is there. So I'm the chairperson of the dialysis vascular access committee of
Yeah.
for the abstract.
I think we should congratulate Hemant. I was going to announce this. Good you. But
So
yeah.
but I had to choose 7 moderators, and now I'm supervising them. So, but that
Right.
was very clear: geographical disparity, gender equality. I mean, all these points were mentioned in the mail upfront, that I have to be very
Right.
sure that there is equal distribution among all the participants.
Right. I was in your position last year with the ASN, and I had to choose.
Yeah.
And so, you know, I chose in that same way.
Right.
So, good. Very good.
Thank you. I think we'll close here, and it was a great meeting.
Yeah.
We'll meet again next month.
Good night.
This Friday, Saturday, I think we'll take some more time, and because we would miss a lot of very interesting people like Adrian, Lal, and people. So that is why I'm insisting with Saturday.